आणि मग मी इंट्रोडक्शन देते मॅडमचं आणि मी जाते तिकडे. सेजल मॅम.
बर. अनुश्री मॅम सुरू करू का? अनुश्री मॅम.
ठीक आहे मॅडम, गो अहेड.
बर. थँक्यू मॅम. सुस्वागतम. I, Dr. Shejal Sanghvi, life member of NIMA and coordinator of
म्यूट. मॅडम आवाज गेलाय. सेजल मॅम आवाज अनम्यूट करा.
Hello.
हा, येतोय आवाज.
Am I audible?
Yes.
Suswagatam. I, Dr. Shejal Sanghvi, life member of NIMA and coordinator of NIMA-National Women's Forum, cordially welcome you all on behalf of National Integrated Medical Association Women's Forum Maharashtra State for National Online Webinar uniquely named I, Series 2. Today's topic is Pathophysiology, Investigation and Management of Female Infertility by our beloved speaker Deepali Chinchole ma'am. I say hello to all the dignitaries present here and acknowledge them serially. For that, firstly, I welcome National NIMA Women's Forum IPP, founder of Women's Forum, very popular and respected Dr. Sadhana Kulkarni ma'am. National NIMA Women's Forum desiring President Dr. Vaishali Padghan ma'am. National NIMA Women's Forum encouraging Secretary Dr. Mrunmay Machutkar ma'am. National NIMA Women's Forum pleasing Treasurer Dr. Rashmi Sharma ma'am. Maharashtra State Women's Forum most cherished IPP Dr. Sapna Jagdale ma'am. Maharashtra State Women's Forum promising President Dr. Anushri Mundewar madam. Maharashtra State Women's Forum very efficient and always available Dr. Pragnya Khose, Secretary ma'am. Maharashtra State Women's Forum jolly natured Treasurer Dr. Meenakshi Gawar ma'am. Maharashtra State Women's Forum sincere coordinator Dr. Pallavi ma'am. And Maharashtra State Women's Forum prompt technical team headed by Dr. Shivilpa Korane ma'am and the team. As previously said, NIMA National Integrated Medical Association was established 76 years ago in Delhi on 13th April 1948 and is expanded over 17 states and 2 union territories, having more than 15 lakh life members all over India. This outspreading association has a precise way of its operation. NIMA has 3-tier system of working: local or district branch, state branch, and main central branch. Today, to form a new NIMA branch, locally, minimum 11 eligible integrated practitioners taking life memberships and functioning it as per Constitution NIMA is the only prerequisite. In Maharashtra, we have more than 233 branches around. For togetherness, organizational values, and enriching our knowledge, I appeal everyone here to get associated with NIMA and NIMA Women's Forum. 3 cheers to Maharashtra State PST members for completing 400 registrations for this ongoing webinar national series named I. For membership of NIMA, any BMS graduate or Unani graduate can take life membership of NIMA by filling the membership form and just paying the nominal fees. Even an MBBS graduate and a dental graduate can also take associate membership of NIMA. For further details and information, contact your nearest branch. Now, how did NIMA Women's Forum and other soap societies of NIMA started and its founder and all will be covered in the upcoming series of this ongoing online webinar I. Stay tuned for it. Now it's time to seek blessing of Lord Dhanvantari. For that, I request Dr. Shilpa Kurane ma'am to play Dhanvantari Stavan for all of us. Shilpa Kurane ma'am.
Yes. धन्वन्तरि स्तवन नमामि धन्वन्तरिमादिदेव सुरासुरै वन्दितपादपद्मम् लोके जरारुका भयमृत्युनाशनम् दातारमीशं विविधौषधीनां शङ्खं चक्रं जलौका दधदमृतघटम् चारुदौर्भिश्चतुर्भिः सूक्ष्मस्वच्छादिरुद्रम् अंशुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्भोज्वलाङ्गं कटितटविला सच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं त्वं निखिलगदवना प्रौढदावाग्निलीलम्
Thank you, Shilpa ma'am. Now I'll briefly introduce our chairperson and co-chairperson and welcome both of them. We are blessed to have a chairperson and a co-chairperson, both are the professor of their respective subjects. So let me start with our chairperson, Baljot Kaur ma'am. She is joint secretary at Central NIMA Obs Gynae Society. She is professor in Prasuti Tantra and Stri Rog department at SKS Sarbha Ayurved, Punjab. She has done her MS from Jamnagar, Gujarat. She has vast clinical experience of 21 years, including 13 years of teaching. She is well-rounded personality. So is our core chairperson. She is executive member of NIMA Nagpur Women's Forum. She is executive member of NIMA Proctology Society. She is joint secretary at NIMA Surgical Society. Our Sheetal Asudkar ma'am is presently working as professor, HOD of Shalya Tantra and PG Dean at MGACH Research Center, Savangi, Wardha, Maharashtra State. Her expertise is in Ayurveda oncology, leech therapy in pain management and healing wound. She has vast clinical experience of more than 25 years. She is multi-talented and versatile personality. Both of our chairperson and co-chairperson have multiple achievements and skill sets. It would take more than a half an hour to read their accomplished biodatas. We are privileged to have both of them today here on the desk. So now I request our co-chairperson, Sheetal Asudkar madam, to take over and introduce our speaker, Deepali Chinchole ma'am.
Thank you. Thank you very much, Shazal ma'am. Actually, this is a pleasure to again unite with all of NIMA Women's Forum State and Central as associates and office bearers. And once again, come in front of you with the task of introducing today's speaker and one of the, I think, dynamic personalities we have with us. So first of all, let me pay my namaskar to all the dignitaries present here. Meenakshi ma'am, Pradnya ma'am, then Swapna ma'am, and all my dear NIMA friends. And let me start with the given task because we have to rush. We have been given the stipulated time. We have to complete the tasks within the time. So Dr. Deepali Chinchole, I welcome you, ma'am, in this today's webinar. And ma'am, Dr. Deepali Chinchole, Managing Director of Accord Hospitals, has taken pioneering steps in infertility space and was responsible for the first test tube baby in Buldhana district. So she is the second generation doctor and hails from a family of reputed doctors. She has done her MD Ops and Gynecology, has more than 22 years of experience in healthcare. She has been awarded a fellowship at Asia Pacific Institute of Embryology, Singapore, as well as fellowship in infertility at RCOG, London. She utilizes an exceedingly dependable, dynamic calibrating system alongside first rate advances at standard odds of origination. Her doctoral fellowship covered study of reproduction, including reproductive endocrinology, then ovarian biology, reproductive immunology, and the genetics of infertility, and many other accolades she is having. So she spearheads the infertility department at Accord Hospitals. So this is the brief introduction of Madam, what I have got. And without wasting time, Madam, I would like to welcome you for today's topic of yours for the lecture. Welcome, ma'am.
Thank you. So, good afternoon, all. So, first of all, I would like to thank the NIMA members for the NIMA Women's Forum to once again giving me this opportunity to interact with you all. I am really amazed with all the response you people are getting. So today only I am the part of the group. So I just read that more than 400 registrations. So I would like to congratulate the organizing team. So now, before wasting much time, we'll start up with the lecture. Should I start?
Yes, ma'am.
Okay, thank you. So today's topic given to me is pathophysiology, investigations and management of infertility. So the objectives of today's lecture are to describe the epidemiology of female infertility, review the most common findings and causes of female infertility, plan of treatment, outline the plan of investigations, outline the management of known causes of female infertility. So now what exactly is infertility? Basically, infertility is a medical condition that can cause psychological, physical, mental, spiritual, and medical detriments to the patient. The unique quality of this medical condition is that it involves affecting both the patient and the patient's partner as a couple. And I would like to add to this is it is not only the couple, but the whole family and finally ending up with the whole society. So what infertility is for a couple is, it's a medical condition which diminishes self-esteem, social life, as well as checking and social account, causes sudden urges to pee on a stick, cry, scream, and fear of pregnancy announcement. This is what exactly an infertile female feels. And what making baby looks like for other people versus the infertile couple is, for others, it's in a bedroom. And for these people, it's like making baby looks like lots of injection and lots of money. So coming to real medical definition of infertility, just give me a second. There's some issue. I'm not able to visualize the slide. I'll just call my technical person. Sachin. हा बार वरती करता येईल का? कारण स्लाइडच मला पूर्ण दिसत नाही. हेच बंद करता येईल. विंडो कमी नाही करता येणार ना तो नाही. तरी ते खाली हा ठीक आहे. That should be okay. I'm sorry. Yeah. So coming to the medical definition, it is defined as not being able to get pregnant or conceive after 1 year or longer of unprotected coitus. As fertility in women is known to decline steadily with age, some providers evaluate and treat women aged 35 years or older after 6 months of. So if the female is below 35 years, we say that we can wait for 1 year for natural conception. And if she's older than 35 years, it has to be within 6 months. Now, as per an American Society of Reproductive Medicine, 85% of women would conceive within 12 months. So if we take a group of 100 women and they undergo a natural conception, so 85% of them will conceive naturally within 12 months. So fecundability is said to be 25% within first 3 months of unprotected intercourse, and then it is decreased to 15% for the remaining 9 months. So within 3 months, 25% of them will conceive, and after that it is 15% will conceive. So it is very, very obvious from that 12 months of, if it's more than 12 months, we have to investigate the patient. Now, what are the normal regular etiology or causes for infertility? In 30% of infertile couples, the female infertility was the cause. In 10% couples, both the male and female causes were identified. In 30%, there was only a male factor. Now, in most common identifiable factors for the female infertility are in ovulatory, if we take the female factor, the ovulatory disorders are 40%, endometriosis 15%, pelvic adhesions 12%, tubal blockage 11%, and other tubal or uterine anomalies 11%, hyperprolactinemia 7%, and unexplained infertility the rest of the group. So there are certain patients we won't find a documented cause. Definitely there has to be some cause, but still our scientific interventions are not able to find out a cause. So these couples we label as them unexplained. Now coming to the epidemiology, as a woman gets older, her chances of infertility increases. In women aged 15 to 34, infertility rates from the range of 7.3 to 9.1%. In women's age 35 to 39 years, the infertility rates increase to 25%. Lastly, women from ages of 40 to 44 years had a 30% chance of infertility. And worldwide, 2% of women aged 20 to 44 were never able to have a live birth, and 11% with a previous live birth were unable to have an additional birth. So infertility is a global issue affecting millions of people, and approximately 1 out of every 6 couple experiences infertility in their lifetime. So now coming to ovulatory dysfunctions, WHO now has divided the ovulatory dysfunction into 4 classes. First is the hypogonadotrophic hypogonadal anovulation. I'm going to detail it further in each slide. Normogonadotrophic normoestrogenic anovulation, that is polycystic ovarian syndrome. Hypergonadotrophic hypoestrogenic anovulation, that is premature ovarian failure. And hyperprolactinemic anovulation, that is pituitary adenoma. Now coming to the first class, that is hypothalamic amenorrhea. Now, what exactly is the hypothalamic amenorrhea? This is hypogonadotrophic hypogonadal anovulation. Now, hypogonadotrophic means here the GnRH hormones are less. Finally, going ahead with the, so if we see this chart, and what happens if the patient, there are certain groups where there are decreased calorie intake, associated weight loss, or excessive exercise leads to elevated cortisol. Now, excessive exercises or less calorie intake, that will lead to increased cortisol, which stimulates the hypothalamus, which acts on the hypothalamus and decreases the gonadotrophin releasing hormone secretion. Now, if there are less number of gonadotrophin releasing hormones, the pituitary again is not stimulated, and therefore there is less of FSH and LH, and finally less of estrogen, leading to anovulation. So the decreased or absent pulsatility in GnRH results in a decrease in the release of gonadotrophins, follicular stimulating hormone, and luteinizing hormone from the anterior pituitary gland. These 2 deficiencies finally result in an abnormal follicle growth, anovulation, and low estrogen levels. The FSH and LH will have variation ranging from normal to low, but the hormone ratio will resemble a prepubertal female with FSH slightly higher than LH. Second class is normogonadotrophic normoestrogenic anovulation, which is there in the polycystic ovarian syndrome. Now, PCOS accounts for almost 85% of all the anovulatory patients. Now, whatever we have seen, there are 4 classes. Of that, 85% is found by polycystic ovarian syndrome. Now, polycystic ovarian syndrome affects 8% of all reproductive aged females. Polycystic ovarian syndrome can be diagnosed using the Rotterdam criteria, which requires at least 2 or 3 below listed criteria in the absence of other pathological causes. So first is oligoanovulation or anovulation, clinical signs of hyperandrogenism, polycystic ovaries demonstrated on the ultrasound. Now, infertility caused by PCOS is thought to be associated with a dysfunction in developing a mature follicle leading to anovulation. The FSH and estrogen will be within normal laboratory limits. The LH can be either normal or elevated, as we have seen that there is slightly a higher level of LH, so FSH and LH ratio may be deranged. The pathophysiology basically behind the PCOS and infertility is not well understood, but classically abnormality of pulsatility of GnRH is described as a possible underlying cause. Now, correlating the high of arrested follicles and polycystic appearing ovaries in the elevation of anti-Mullerian hormone. So in polycystic ovarian syndrome, the anti-Mullerian hormone AMH is supposed to be at high levels. Now, the third class is the hypergonadotrophic hypoestrogenic anovulation. Now, in this category comes the premature ovarian insufficiency and ovarian resistance associated with the female's age. Now, as we have seen that women's age affects fertility, which is due to well-studied phenomenon of a steady decline in the quality and quantity of the patient's oocytes. Now, only quantity is not important, but the quality of the oocytes is also very, very important. So in terms of quantity, if we see that the female fetus at 20 weeks gestation has roughly around 6 million follicles. The newborn, when the baby is born, this comes down to 1 million, and at the onset of puberty, the number of follicle decreases to around 3 lakhs. Now, though at puberty, the female has 3 lakhs of eggs, but still we say that there are only 500 to 700 available for ovulation. Because what happens is during ovulation, the other follicles, they slightly grow to a certain level and they become atretic there because of oxidative stress, because they have to support one follicle, which is a natural phenomenon. And that is why many of them, they undergo atresia due to oxidative stress. Now, the rate of follicle loss continues through a woman's life and begins to increase in rate around her mid-30s. Now, again, it is the same thing which we are talking about. Ovarian quality is also, as I said, is essential to overall fertility. The loss of oocyte, as I said, equality through loss of the oocyte quality throughout a woman's life is associated with the meiotic non-disjunction resulting in aneuploidy. Now, instead of remembering these difficult words, we only need to understand that as the one follicle is growing, the other follicle, they undergo atresia due to oxidative stress, and that is why along with the age, these follicles, we say that the follicles are also aged, and the chances of abnormal babies or missed abortion or abortions, it increases. I'm not audible?
Now audible, ma'am. Audible, ma'am.
Yeah. So now ovarian reserve refers to the ability of the ovaries to provide viable eggs that can potentially develop into a healthy pregnancy. And as I told you, egg quantity as well as the egg quality is very, very important. Now, what are the tests for this? We'll go ahead in the investigations. Now, coming to the fourth factor, which is the hypergonadotrophic hypoestrogenic anovulation, where we call as premature ovarian failure. Now, along with age, there are certain factors which act on the ovary and maybe they cause the premature ovarian failure. Common are autoimmune diseases, infections like mumps or oophoretis, tuberculosis, malaria, CMV, varicella and shigella, and induced premature ovarian failure is in bilateral oophorectomy. If the patient has malignancy of ovary or something like that, then maybe we have to remove the ovaries. Many chemotherapeutic agents Excuse me, again, there is something happening on the screen.
Someone's
Technical team can please take care of this.
someone's whiteboard is on. Someone's whiteboard is on. Please make it off.
I'll continue, but I think we need to
Yes,
take care because
yes,
it's
we will see, ma'am. And one request, please make the screen full screen, ma'am.
then there are in certain malignancies which require radiation, that also may lead to premature ovarian failure. And there are certain environmental toxins, and in menorrhagia or severe bleeding cases, many times these days we are doing an interventional radiology procedure which is called as pelvic vessel embolization, that again may lead to premature ovarian failure. Now, these days we are seeing a rapid increase in cases of premature ovarian failure. I have seen females aged 24, 25, 28 with premature ovarian failure, and it's really a devastating thing to tell them that she cannot become pregnant with her own eggs. And what exactly is causing is we are still not sure. Mostly we feel that these are the environmental toxins which maybe are acting. So coming back to the fourth factor, which is hyperprolactinemia, which causes anovulation. Now, prolactin, it causes the suppression of the hypothalamic gonadotrophin releasing secretion, leading to a low LH, resulting in anovulation, corresponding to oligomenorrhea or amenorrhea. Now, why there is hyperprolactinemia? So one main cause we know that maybe it's pituitary adenoma, but many times we have seen that in cases of severe PIDs, tubercular infections, there may be a reactionary hyperprolactinemia. And once there is prolactinemia, there may be anovulation and finally maybe amenorrhea as well. So prolactin serum levels of 20 to 50 nanogram per ml causes insufficient progesterone release from the corpus luteum, which shortens the luteal phase. Along with anovulation, it is seen that maybe there is a theory which says that progesterone release is also hampered by the prolactin, and that is why there is shortening of the luteal phase, and maybe which leads to infertility or maybe missed abortion or spontaneous abortions in these cases. A concentration, but how to diagnose pituitary adenoma is, along with prolactin, most of the times there has to be a TSH rise as well. So if the prolactin is very high, we need to understand that we have to do a TSH level as well. And if TSH and prolactin both are high, then the patient has to undergo an MRI to rule out the pituitary adenoma. So next cause is the endometriosis. So endometriosis, it is defined as endometrial tissue outside the uterine cavity. The diagnosis is basically based on histological identification of the endometrial glands and or stroma outside the uterus. Most of the time, these are diagnosed on laparoscopy or ultrasound, maybe if there are tubo-ovarian masses. Severe forms are diagnosed on sonography as well. So endometriosis is most commonly found in the pelvis, but can spread throughout the entire abdomen and affects 10 to 15% of the reproductive age of the women. Of women with endometriosis, 40 to 50% will experience infertility. So it's a very, very high incidence. Endometriosis, it is categorized into 4 stages by the ASRM. Now, what are the stages? So stage 1, it's minimal, and stage 4, severe. Endometriosis, it is known to cause infertility, but the pathophysiology is thought to change according to the stage. Now, for stages 1 and 2, the infertility is believed to be associated with inflammation, with increased production of prostaglandins and cytokines, macrophages, and natural killer cells. Now, these will affect the endometrium as well as the tubal functions. The inflammation impairs ovarian and tubal functions, resulting in defective follicular formation, fertilization, and implantation. In stage 3 and 4 are associated with pelvic adhesions and or masses which distort the pelvic anatomy. This will inherently impair the tubal motility, oocyte release, and sperm motility. Also, advanced endometriosis is hypothesized to impair the folliculogenesis and reduces the fertilization potential as well. Due to severe adhesions, what happens is that there is a negative atmosphere around the ovary, and because of this, as I said, that oxidative stress, maybe the follicles, they don't reach to the final stage of maturation. Now coming to the fourth factor, which is pelvic or the tubal factor. Now pelvic and tubal adhesions along with the uterine and tubal abnormalities account for a large portion of female infertility. Infectious processes within the abdomen are the leading cause for pelvic tubal adhesions. The most common infection processes to affect infertility is the PID. Now, the microorganism that carries the greatest risk of infertility in association with PID is the Chlamydia trachomatis. Now, 1 in 4 women with tubal factor infertility will have positive antibodies to the chlamydia, which are inversely proportional to the pregnancy rates. Now, the number of PID episodes and the severity play a role in the likelihood of infertility. Now, one study demonstrated that pregnancy rates following PID were 89% after 1 episode, 77% after 2 episodes, and 46% after 3 episodes. In terms of PID severity of mild, moderate, and severe, the live birth rate were 90%, 82%, and 57% respectively. So second tubal factor is the hydrosalpinx. Now hydrosalpinges, what are these? These are tubal abnormality caused by acute and chronic inflammation. So in chlamydia as well, there can be a hydrosalpinx as well. Now what does this hydrosalpinx do? The hydrosalpinx basically, it leads to tubal obstruction, which blocks the distribution of physiologic fluid in the fallopian tube and results in fluid accumulation. Now this fluid accumulation gives it the picture as this, which is a swollen tube, which we feel that it's a fluid filled tube, and that is why it is called as hydrosalpinx. The belief is that these hydrosalpinx, now second factor which leads to infertility because of hydrosalpinx is the retrograde flow of toxins and prostaglandins. Now, if there is an infection in the tube and the tube is swollen, there has to be certain toxins and prostaglandins which are released. Now, these prostaglandins are released retrograde inside the uterus as well, and then implantation is also hampered because the endometrial receptivity is impaired. Now, literature has demonstrated that patients undergoing in vitro fertilization have a 50% decrease in pregnancy if a hydrosalpinx is present. So many times what we do, we take the patient's consent, and many times if there are severe hydrosalpinx cases, we have to clip the tube. We have to remove the hydrosalpinx, and then we have to ask the patient to undergo the IVF cycles, because it definitely, though in IVF we don't need the tubes, but the implantation is hampered, and that is why many times it is advised that we have to advise the patient for the salpingectomy or removal of the hydrosalpinx. The fourth and last most important factor is the uterine causes for infertility. Now, uterine causes of infertility are associated with either certain space occupying lesions or reduced endometrial receptivity. Now, space occupying lesions are fibroids, or there may be certain congenital anomalies. Now, regarding the fibroids, only submucosal or intracavitary fibroids impair the implantation. Now, if this is the pedunculated submucosal or this is the submucosal, the subserosal ones, they generally don't interfere with the pregnancies, but the submucosal and intracavitary, this is an intracavitary fibroid. So they definitely hamper because they are the space occupying lesions in the cavity of the uterus. So there is no space for the implantation. Now, congenital uterine abnormalities, all types of congenital abnormalities, but as I told in my other lecture also, they are not supposed to be a direct cause, because many times we have seen that patients with uterine abnormalities have become pregnant, have been delivered at full term as well. So interestingly, one study demonstrated that prevalence of congenital uterine abnormalities in the fertile and infertile population is the same. That is what I was telling. So infertility due to congenital uterine abnormalities thought to account for roughly 8% of the female causes of infertility. However, 25% of women with a late first trimester or second trimester miscarriage are found to have congenital uterine abnormalities. So there are chances of preterm labor, there are chances of miscarriages, second trimester abortions in these cases rather than infertility. Now, coming to evaluation, the first and foremost thing which The most important, I feel, is the history. The first consultation of the patient has to be a counseling session because they need to counsel regarding all the things, and we need to ask them certain specific questions which are very, very important. First and foremost is the infertility duration, because for both, for the men as well as for the women, because the chances of normal conception, they decrease as the age of the marriage increases. So infertility duration, if the infertility duration is more, the chances of normal conception are less. So many times what we do is we divide this into 2 years of infertility, 5 years of infertility, and 7 years of infertility. If a patient comes with 2 years of infertility, we do normal, regular, and we are not very invasive investigations, but more than 5 years, definitely we have to treat these patients, because if it's a 5 years of infertility, definitely the problem has to be a major one, and we have to do certain invasive investigations and treatments as well. So prior fertility relationship in both husband and wife, because many times maybe it's a second marriage and they would have had a previous pregnancy, though, so that itself would come to give you certain direction to the diagnosis. Medical and surgical history is very, very important in both of them. If there are certain medicines which have been taken, like anabolic steroids or cancer therapy, and then alcohol, drug, sport, definitely it is important. Sexual dysfunction, if the male partner is facing any sexual dysfunction, definitely a use of tight underwears, or we need one more thing which we need to ask is their working environment as well. We know that if they are working in hot furnaces or areas of where there is a lot of heat generation, definitely that hampers the sperm production. In the females as well, we have to definitely ask the infertility duration, prior fertility relationships, detailed menstrual history. It is very, very important. The menstrual history itself will tell you if she has some ovulatory cycles, or there are any problems related to the endometrium as well. If she has had any prior pregnancies, fertility in other relationships, if she has had any IUDs or OC pills or Depo-Provera, and frequency of intercourse and sexual dysfunction. These are the most important factors which we need to rule out in the first consultation itself. Now, coming to the second important part is the physical examination. So these days I am seeing that history and physical examination, these things are being very, very rudimentary in our practice, but I feel it is very, very important as far as infertility goes, because the history itself, looking at the patient itself, there are many things which we can diagnose, and we can take a direction for further investigations as well. Investigations are important, but history and physical examination needs its own importance as well. So we need to see the vital signs and BMI particularly, because body mass index is important. Body mass index is supposed to be inversely proportional to the incidence of infertility. If the body mass index is high, there are high chances the patient may have anovulatory cycles. So thyroid evaluation is important. Breast examination for galactorrhea, because if she has galactorrhea, there are chances that she will have hyperprolactinemia. Signs of androgen excess, like she may have acne, hirsutism, coarse hairs, then appearance of abnormal vaginal or cervical anatomy. So per speculum and per vaginal examination is as well important. So because many times in the per vaginal examination, we'll come to know about if there are any ovarian cysts, if there is a fibroid, if there is adenomyosis, these many things which can be ruled out in the per vaginal examination itself. So transvaginal ultrasonography is often done at the bedside part. This is done definitely with the gynecologists and the infertility centers. We generally have we do the transvaginal examination there, the sonography there and then itself. So now, what are the 5 diagnostic evaluation tests which we need to do? First and foremost, I always advise that it has to be semen analysis, because it's the most simple, non-invasive, and it will rule out the 30% factor which is there, which we say that 30% is the male factor. Now, if the semen analysis is normal, we only have to concentrate on the female and carry out all the investigations on her. Second is the assessment of ovarian function and reserve, because again, these are the non-invasive tests. Blood test and sonography will help us. Assessment of the uterine cavity, assessment of fallopian tubes, and then the endocrinological serum studies. Now, this is the evaluation of the male fertility, simple semen analysis. It's a small video which will show that this is the microscopic picture of the when we do the semen analysis. So in the semen analysis, what we look at is the ejaculatory volume, the sperm concentration, the sperm numbers, percent motility. How is the percent motility and which type of motility is there? If the morphology of the sperms is normal, if there is any agglutination of the sperms, viscosity of the semen is as well important. So now this is the normal sperm count. And with normal motility. And against this, you can see. Now there is only, you'll be able to see only one sperm and which is fairly motile. And this is the normal semen analysis. So there are certain terms which are important in abnormal sperm structures. This is normozoospermia is normal motility and normal concentration of the sperms. We say that 15 million sperms per ml are important. Oligozoospermia, where the number is less. Asthenozoospermia, where the motility is less. Teratozoospermia, where the morphology is deranged. There are certain morphologically abnormal sperms. Azoospermia, where there are no sperms, and in aspermia, where only we see there is no maturation of the sperms. So now these are certain abnormal sperms. This is round-headed sperms. We see that. We see here, it has to be conical like this. Here it is a round-headed sperm. Here there are two-headed sperm. Here it is a conical-headed sperm. So these are certain abnormal morphology in the sperms. I'm not going into detail of the male factor because I think you have a separate lecture on the male factors. So now coming to the evaluating the female infertility. Now first exam, as we said that it has to be the patient's history and the physical examination. Then we rule out the ovulatory status. Now for ovulation, the simple test is the mid-luteal serum progesterone or ultrasound scans, endometrial biopsy. We used to do previously when sonography was not that rampant. We used to do the endometrial dating. We used to take the endometrial biopsy and send it to see if it's in the secretory phase. Basal body temperature, and now these days LH kits are available, so we can give those to the patients and document the ovulation on the LH kits as well. Cervical mucus as well, that test also can be done to see if the ovulatory status. For the ovarian reserve, we do the basal LH, FSH, E2, inhibin B, anti-Mullerian hormone. We look at the FSH and LH ratio and basal follicular count. So FSH, antral follicular count, and anti-Mullerian hormone is the triad, which is very, very important to see for the ovarian reserve. For uterine factors, we do the ultrasound scans, hysteroscopy, laparoscopy, HSG. For tubal factors also, HSG and laparoscopic chromoperturbation. Now for the ovulatory status, assessment of ovarian function can be simple as the menstrual cycle history, as I told you. If the cycles are regular, we can say that the ovarian function is normal. Women with predictable regular cycles and predictable menstrual flow are more than likely ovulating. At home urinary LH predictor kits detect a mid-cycle LH surge, which is indirect evidence of ovulation and helps identify the fertile window. Ovulation can also be detected by a cycle day 21 progesterone serum level, or more accurately, a mid-luteal phase progesterone level. The lab should be taken approximately 1 week before menses, and a progesterone lab value of greater than 3 nanogram per ml is evidence of ovulation. More accurate means of ovulation is follicular monitoring ovulation study. Now, I emphasize particularly here that generally what we do is we advise follicular monitoring from day 7, day 9. But I generally would emphasize that we should do a basic day 2 scan to rule out remnant follicles from the previous ovarian cycle. What happens is there are certain remnant follicles on day 2. And if we directly see the patient on day 9, that follicle also be counted as a growing follicle for this or the dominant follicle for this cycle. And many times it can give us a misdiagnosis of ovulation. So we have to do a day 2 scan as well. Now, evaluation of ovarian reserve, as I told you, now day 3 FSH, estradiol, anti-Mullerian hormone. The theory of day 3 FSH and estradiol is that women with good ovarian reserve have early sufficient ovarian hormones from small follicles to allow FSH to remain at a lower level. In women with reduced follicle count, the insufficient hormone causes a lack of inhibition resulting in elevated FSH. FSH levels less than 10 international units demonstrate likely normal ovarian reserve. So FSH has on day 2 or day 3 has to be less than 10. Now, if it is 10 to 20, it's intermediate, and FSH greater than 20 is a poor prognosis of spontaneous ovulation due to low ovarian reserve. Now, according to one study, the pregnancy rates per normal menstrual cycle corresponding to FSH levels above are 32%, 17% to 19% and 3%. Day 3 estradiol less than 80 picogram per ml is considered normal with adequate ovarian reserve. Now, values greater than 80 picogram per ml result in lower pregnancy rates, and values more than 100 picogram had a 0% pregnancy rate. So the most important one, the AMH. Now, what is AMH? AMH is a hormone which is expressed by preantral follicle, and preantral and antral follicles, representing a marker of ovarian function that can be measured at any time during the cycle. So for AMH, it need not be a sample of day 2 or day 3. We can take it in any time of the cycle, because it is now these follicles don't come under the cyclical hormonal menu, and that is why if the dating of this hormone is not required. Now, AMH levels will gradually decline throughout a woman's natural reproductive life to the point of undetectable levels at the menopause. Now, AMH level seems to be a good predictor of exogenous gonadotrophin response. So we have taken this as in whenever we give them what dosage of hormones we have to give, AMH is a very good indicator. Now, 0.05 nanogram per ml predicts difficulty getting more than 3 follicles to grow. Less than 1 shows limited egg supply that may require more aggressive ovulation induction protocols. 1 to 3.5 shows normal values, and more than 3.5 shows ample supply and may require mild induction to prevent ovarian hyperstimulation syndrome. Now the fourth factor is the antral follicular count. This is done on day 3, and we say that the measuring number of follicles has to be between 2 to 9 in the ovaries with transvaginal ultrasound in the early follicular phase, and is also an accurate measure of ovarian reserve and predictive of ovarian response to stimulation. So antral follicular count, FSH and AMH, we have to consider all these three to say that the patient has less ovarian reserve or she has a normal ovarian reserve. Now, for tubal evaluation, the gold standard definitely is a laparoscopy chromoperturbation. It is indicated as a first-line diagnostic test for suspected pelvic adhesions, endometriosis, or other pelvic pathologies. However, due to high specificity and being less invasive, we carry out on HSG, which is hysterosalpingography, is commonly used for the first-line evaluation. As I told you, 5 years more, if the patient has an infertility of more than 5 years, it's always better that we go ahead and do the laparoscopy instead of wasting time and doing her HSG. So my moderate and severe infertility, it will definitely vary for the tubal evaluation if you have to do a laparoscopy or HSG. The ability to detect abnormality is best for proximal occlusion followed by distal occlusion. However, the HSG has poor predictability for intrauterine tubal adhesions. Because if there are intrauterine tubal adhesions, it will definitely show that the fluid, what we do in HSG is, now this is the uterus and these are the tubes. Now what we do is we insert a cannula in the cervix and we inject a dye, radiopaque dye, and we take the X-ray films. Now the dye passes through the tubes and comes out of the uterine. Now this will show that only the tubes are patent or not. If there are adhesions, still the tubes will be open, but the tubal function won't be normal. So on laparoscopy, now here we see that there are endometriosis, fallopian tube adhesions, uterus. So laparoscopy, it's a direct visualization, so it will give you better view for the tubal factor. Now this is a chromoperturbation. We are seeing a dye coming out of the tube. So it's the same way we do that. We push methylene blue from the uterus and it comes out of the tube and we see that. And here we can see the structure of the tubes. If there are adhesions, the tubes are distorted, all these things, we can visualize this on laparoscopy. So here we see the hydrosalpinx on, this is a hysterosalpingography picture. This is a sonography picture, and this is a laparoscopic picture of hydrosalpinx. Now, coming to the evaluation of the uterus, again, the gold standard for assessing the uterine cavity is the hysteroscopy. Now, these days, office hysteroscopy is available. It doesn't require anesthesia as well. Many people do it without anesthesia in their OPDs as well. It is done as an OPD procedure. It allows a direct visualization of the intrauterine pathology and provides an opportunity for immediate surgical correction. Although hysteroscopy is considered the gold standard, a less invasive approach, which is more commonly utilized with a saline infusion sonogram. Many people do saline infusion see on the sonography probe if the tubes are filling, and if they can see the saline is infused actually, because dye is not required in sonography, and if the fluid comes down in the pouch of Douglas. The saline infusion sonogram is highly sensitive and specific for intrauterine abnormalities. Now here, if there are intrauterine abnormalities, a space occupying lesion is seen on the sonography. So these are certain pictures of hysteroscope. So here it's a video camera, and we insert it in the uterine cavity, and we can see this. Now these are some intracavitary fibroids. Here it's an intrauterine septum. These are the polyps, and this is a normal uterine cavity. And these two, what you are saying, are the ostia, the tubal ostia, which are opening in the uterus. This is a bicornuate uterus on hysterosalpingograph, and it is seen this way in the hysteroscopy. So second factor which needs to be seen in the uterus is the endometrial receptivity. Now this can be assessed by transvaginal sonography Doppler, hysteroscopy, and endometrial bacteriology. We take the endometrial biopsy and send it for testing. We do the bacterial test as well, and we are seeing not many bacteria, and many times if we treat this patient on a regular basis with the antibiotics which are sensitive to the bacteria, many times it is seen that the endometrium levels are reached to the normal. So on sonography, this is the endometrial thickness which we see, and we say that it has to be more than 10 mm, and Doppler studies will show that the blood supply to the endometrium is as well. Now this is a picture of a saline sonography. This is a space occupying lesion which we are seeing on the uterus. This is a polyp. Now coming to the treatment part. Now this differs according to the factors which are involved. So fertility, for female infertility, if there's an ovulatory failure or dysfunction, we do the ovulation induction. For tubal factor, we do control ovarian stimulation along with IVF. Endometriosis, IUI, if there are patent tubes, or control ovarian stimulation, then IVF. If there are certain adhesions or severe endometriosis, we have seen that the tubal morphology is distorted, and we have to go ahead with the treatment of IVF. In male factors, if it's a subfertility, the sperm count is between 10 to 15 million, and we have fairly motile sperms in the semen. We can go ahead and do an IUI with or without ovulation induction, but generally we do it with ovulation induction. And if there's a severe male factor, definitely we have to undergo the treatment of IVF or ICSI. Now in unexplained, we do all types of treatments, and we have to slowly go ahead with the treatments. Like we will do the ovulation induction because we don't know what exactly is causing the infertility. So we will do the control ovarian stimulation, then IUI, then we will go ahead with IVF and ICSI. So first and foremost is the lifestyle changes in the management. So if women with extremes of body mass index frequently present with infertility and ovulatory dysfunction, women with BMI of less than 17 kg with a history of intense exercise regimes, or women with eating disorders are likely to develop hypogonadotrophic gonadism, which causes decreased diseased pituitary gonadotrophin secretions. Now, one study demonstrated that importance of behavioral change in inducing ovulation. Of the women who received individual directed therapy to correct energy deficiencies or behavior problems, 87% resumed regular ovarian function to correct the abnormal BMI. Now, women with BMI greater than 27 with anovulation can improve ovulation with weight loss alone. Now, multiple studies have shown that loss of 10% of body weight will restore normal ovulation in 50 to 100% of women in less than 1 year. Even though weight loss is important for many aspects of patients' life, one study showed that obese women who received counseling and interventions for weight loss before infertility treatment did not have higher pregnancy or live birth rates compared to obese women who had infertility treatment without weight loss intervention. Therefore, a specific BMI is not required to initiate a fertility treatment, but definitely the patient has to be fit. We have to advise them weight reduction if we have to undergo with higher treatments like IVF or ICSI. So coming to the control ovarian hyperstimulation, the drug which we regularly use is clomiphene. It is the first line medication for infertility of unknown origin and and also for the patients of ovulatory dysfunctions. Now, how clomiphene acts is clomiphene basically it's a selective estrogen receptor modulator. So it mimics the action of estrogen, but it has a selective action of estrogen. So it has a certain type of action on the ovary and other type of action on the endometrium. So clomiphene is a selective estrogen receptor modulator with estrogen antagonist and agonist effects that ultimately increase gonadotrophin release from the anterior pituitary. Clomiphene is dosed starting at 50 milligrams, starting on cycle day 2, 3, or 4, or 5 for sequential 5 days. Generally, regularly, we started on day 2. The couple is encouraged to have intercourse every other day for 1 week, beginning 5 days after the last pill. Now, however, the odds for pregnancy may be increased when clomiphene is combined with intrauterine insemination. There is little difference in the results of ovulation, pregnancy, or live birth regarding which day the medication is start between the cycles day 2, 5. So I would advise that whenever we are giving more than 50 milligram of clomiphene, it has to be combined with the ovulation study or follicular monitoring as well. Because many times what happens is with 100 milligram of clomiphene, maybe if the patient is sensitive, she will develop n number of follicles. There won't be a hyperstimulation, but definitely if there are many follicles, again, the purpose is not solved and we are finally causing the loss of important oocytes, which we may require for her future treatments. Second regularly used drug is the letrozole. Now, letrozole has a similar type of action with like clomiphene, but what it does is it has an aromatase inhibitor that prevents estrogen production by preventing the conversion of androstenedione and testosterone to estrone and estradiol. Letrozole, basically, FDA has approved it for extended adjuvant treatment of breast cancer, and its use for ovulation induction is still considered as off-label. However, there is an abundance of scientific literature and multiple committee opinions that support both the efficacy and safety of its use in ovulation induction, and these days we are regularly using letrozole. Letrozole is dosed starting from 2.5 or 5 or 7.5 milligram per day from day 3 of the cycle, with intercourse every other day for 5 days after completing the medication, which is similar to clomiphene. Now, according to ACOG, letrozole should be considered the first-line treatment for women with PCOS over clomiphene. So, in polycystic ovaries, we should use letrozole and not clomiphene citrate. Now, what clomiphene versus letrozole, if we have to compare, the benefits of letrozole are more over clomiphene because it causes higher rate of monofollicular development. So there is no multifollicular development in letrozole. That is why it is preferred. And that is why it decreases the multiple pregnancy rate. It has a shorter half-life. Clomiphene has a higher half-life. Non-antiestrogenic effects on the endometrium and central nervous system. So it doesn't affect the endometrium, so chances of pregnancy are more. Now, lower estradiol levels, which is benefit for women with breast cancer undergoing IVF. Letrozole's beneficial profile compared to clomiphene may replace clomiphene as a first-line treatment in future. Now, gonadotrophin injections, which are used in control ovarian hyperstimulation, it is a more intensive medical regimen used for anovulatory disorders. Gonadotrophins are beneficial as second-line treatment option for women who fail to conceive after multiple cycles of clomiphene or letrozole. However, it is important to discuss that close monitoring is required while using more invasive and intensive gonadotrophins. Transvaginal ultrasounds are used to monitor follicular growth every 2 to 3 days during the late follicular phase to evaluate mature follicles. When the mature follicle is greater than 18 mm in diameter and estradiol for greater than 200 picograms, once the mature follicle is identified, we give her HCG, recombinant HCG 250 milligrams subcutaneous injection, or intramuscular if you have to give, then 10,000 international urinary derived HCG is given to trigger the ovulation. Once the trigger is short is given, IUI has to be done 24 to 36 hours. Now here there is a many times what we do is we do IUI, or we ask the patient to have regular relations after the rupture of the follicle. Now we need to remember one thing very, very importantly here is the life of the oocyte or the fertility of the oocyte is there till for 24 hours. And if the sperm enter the uterine cavity, their life is for 72 hours. So if after the ovulation, if we tell the patient documenting the ovulation on ultrasound and we ask them to have intercourse after that, maybe we have lost this window of 24 and 72. So what we need to do is we need to ask them to have a sexual intercourse on a regular basis once we have given them the HCG, because the sperms will remain them if the ovulation occurs after that also. So we need to understand this for the IUI as well. We have to perform IUI within 36 to 48 hours, though there is no documented ovulation on the sonography. So now what are the indications for IUI? IUI, as we all know, intrauterine insemination, in which patients we perform an unexplained infertility, if failure to conceive after ovulation induction treatment, if there is a oligospermia male factor, there is ejaculatory failure, or there is retrograde ejaculation. Now the goal in IUI is to maximize the chances of fertilization by increasing the number of eggs, positioning the sperm closer to the eggs, but there have to be patency of the tubes has to be checked. Now many times what happens is when there is azoospermia and donor sperms are used, we have to do a tubal test first. Many times it happens that the patient has undergone cycles of donor IUI and patient hasn't conceived, and later on we come to know that she has a tubal factor as well. Now why this happens is many times the azoospermia or severe oligospermia is because of infections. Now this infection, many times it travels the uterine cavity, it travels to the tubes, and the tubes are blocked. So regularly we need to understand that if we have to treat the patient with IUI, the tubal patency has to be done before that. IUI also can be used as a functional test for tubal function, as I mentioned in my earlier lecture as well. When there is we know that the tube is patent on his HSG and hysteroscopy or chromoperturbation, but we don't know the activity of the tube. The tube has to pick the egg and bring it to the infundibulum portion where the fertilization occurs, and then again it has to cause with the motility, the fertilized egg is also left in the uterine cavity. So this movement of the tube is very, very important, and this functionality can be tested indirectly with the IUI, and it is called as a tubal challenge test as well. So what we do in IUI is we take the sperm sample and we process it, and then with the help of the catheter and sonography guidance, this semen sample, the processed semen sample, is placed here in the uterine cavity just near the ostia, so that the distance of the sperm is reduced here. The distance they have to travel is reduced. So coming to, I'll just give a short brief of IVF treatments. So the art of making babies. So it is a process by which the oocyte is fertilized by a sperm outside the body, and then the gamete is transferred inside the uterus. Now, who needs IVF? The failed other treatments, tubal damage, significant male factor, absent uterus. In these patients, we do the surrogacy. Then carriers of genetic disorders and cancer patients. So IVF, it consists of basically 7 steps. First is the downregulation. Second is the controlled ovarian stimulation, the maturation of the oocytes retrieval, fertilization and incubation of gametes, embryo transfer, and luteal support. So first is the downregulation, which starts on day 21. Then the stimulation, which starts on day 1. Then we do the sonography, that is follicular monitoring. Then the egg collection is done when the most of the follicles are 18 to 20 mm, and embryo transfer and the pregnancy test. So There are short protocols and long protocols for the down regulation. So if it's a long protocol, we start the GnRH agonist in a prior cycle on day 21. Once the patient has the menses, then we start her the stimulation with FSH or HMG. And then we do the follicular monitoring. We give HCG at around when maximum of the follicles are 18 to 20 mm. And once we have given the HCG, exactly at 36 hours, we do the retrieval of the eggs, or what we called as the egg pickup. So why the eggs are removed at 36 hours is we don't want them to the follicles to rupture naturally, because it is very, very difficult to collect the eggs from the POD. So downregulation, why downregulation is done? It is done to avoid the premature LH surge and spontaneous ovulation. Now in IVF, we have to remember a basic thing is that we don't want anything to happen naturally, because we have to have a complete control over the cycle. And that is why we downregulate the pituitary, so that the pituitary doesn't cause the LH surge, so that we can time the egg pickup. So we use either GnRH agonist protocol or antagonist, and on that it depends that if it's a long protocol or a short protocol. Now the control ovarian stimulation is done with FSH or HMG. It depends on the doctor's choice. It depends on his own experience, or definitely with the patient's previous experience as well. We give them the GnRH from day 2 of our cycle till most of the follicles reach 18 to 20 mm. And then we, as I told, we give HCG, and at exactly 36 hours, we do the egg retrieval. Now, egg retrieval is done. So we do it as sonography guided, as we do the transvaginal sonography. This is a transvaginal sonography probe, and there a biopsy guide is attached. And with this biopsy guide, we insert one needle through the fornix to the ovary, and from the ovary, we retrieve the eggs in a tube. So this is the picture on the sonography. So this is a needle now coming inside the follicle. And with the help of a suction, we suck out the follicular fluid. Now the needle has entered this other follicle. So in this manner, the eggs are got into a dish, and then they are transferred to the, what happens is there is a egg pickup OT, and combined with that is the lab, and there is a window in between. So we pass on the tube inside in the lab, and in the lab, then the eggs are visualized and they are separated out. And then either we do an IVF procedure or ICSI. Now, what is IVF and what is ICSI is, in IVF, what we do is we take the eggs and we leave the sperms around the eggs. The entry of the egg into the sperm happens in a natural phenomenon. And in ICSI, what we do is we hold the egg and we leave the sperm inside the egg. There is a beautiful video I would like to show. Now, this is a sperm in the. Now, what we are doing is we are trying to catching hold of the sperm. What we do is we immobilize the sperm. Now, the sperm has done a reverse entry here. Yeah, now this is the right way. Now, what we will do is we will get the egg in the position. Yeah. So now this is the egg. So we will hold it with a suction pipette so that it doesn't move when we are pricking the egg. So this is a suction pipette with which we hold the egg in position. This exactly has to be the position. This is the secondary nucleus. So we have to, it has to be perpendicular to the, where we are pricking the egg with the sperm needle. So now we will prick the egg here. We slightly suck a bit of fluid from there, the cytoplasmic fluid. and then we will again push it back. So you can see the sperm coming out of it. Yes. And now we leave it there and we will remove the needle. Now this procedure is called as intracytoplasmic sperm injection. Then we go ahead with the second egg. Now, why all this control ovarian hyperstimulation and downregulation is done is that because in normal natural cycle, we get only one egg. But with IVF or ICSI, we need more number of eggs so that we can increase the chances of pregnancy. Because with one egg, if that is damaged, then the whole cycle will go waste. So that is why we do ovarian hyperstimulation for them and take n number of eggs so that we can work with them. So this is the day 2. Then we after the ICSI, we keep that in the incubator so that, and we see that we document the fertilization on day 2. Then these are the different cycles. So what I was telling you was IVF is we leave the sperms here, and ICSI is we are leaving the sperm inside. This is the fertilization, and then this is the multiple cell stage of the fertilized egg. So coming to the embryo transfer, now there are 2-3 theories for the embryo transfer. These days, what we do is we do only frozen cycles so that we get a better way to work on the endometrium. Previously, we used to do fresh cycles only because we used to do if we do a egg pickup on day 3 or day 4, we used to transfer the egg in the uterine cavity. But these days, we freeze them and keep, and we do the transfers in the natural cycle because it is seen that the pregnancy rates are high if we do them in the natural cycles. So this is a small video of the embryo transfer as well. So embryo transfer is again, this is also done under sonography guidance, but the abdominal sonography. So this is a picture of an abdominal sonography, and this is a small catheter which is coming inside the uterine cavity along with the embryos, and we place them at exactly at the mid level of the cavity. So yeah, so this is the embryo transfer. So to summarize the procedure, what we do is we take the eggs, we take the sperms, we fertilize them, and we place them inside the uterus. So this basically is IVF for test tube baby. Now, what are the risks in in vitro fertilization? Ovarian hyperstimulation. Yes, there may be hyperstimulation of the ovaries. There may be n number of follicles, and it can lead to ovarian hyperstimulation syndrome. Usually, it is not serious and resolves on outpatient department in outpatient management only. But in 1 to 2% cases, they may be severe, and they may require hospitalization. Anesthesia is because egg pickup procedure, we have to do it under anesthesia. Multiple births, yes, there are chances of multiple births. Ectopic pregnancy as well. You will say that now we are placing the fertilized egg in the uterine cavity, and still we have, because many times what happens is there is a negative suction happening at the level of the tubes, and tube can suck the embryo inside them, and there are chances of ectopic pregnancy as well, but not more than normal pregnancies. So cost, definitely cost is a factor for consideration at our end. Psychological distress definitely for the patient. Now, what are the special IVF procedure? Assisted hatching. Now, here we have done the natural fertilization, but what we do in assisted hatching is we break the outer layer of the fertilized egg, and then we do the transfer in them so that it helps in implantation. There are in certain genetic disorders, we do the pre-implantation genetic diagnosis. We can freeze them. These days, it's become very common that the females who don't want to get pregnant at an early age, they can freeze their eggs and keep, and they can become pregnant in their later stages of ages. So secondly, the freezing is done in cases of who have to undergo cancer treatments also. Egg donation for patients who have premature ovarian failure, and surrogacy for patients who have severe uterine abnormalities or absent uterus, which is a congenital defect. In these patients, we can use surrogacy. What are myths and facts? The chances of twins, yes, the chances 1:5. Spare embryos can be frozen. The pregnancy is as normal as any other pregnancy. The baby belongs to the same couple if all the factors are normal. Now, baby is normal as you and me. The baby grows in the mother's womb and not in a test tube. So coming to the end, I think we can have a question and answer session. I have tried my level best to cover all the investigations and treatment part.
Thank you, ma'am. Thank you.
I'm not able to hear actually. 1 minute.
I request your team to play your Accord Hospital's video.
1 minute. 1 minute, ma'am. Madam, I think there is certain issue because I have logged in from our corporate office. So I think there is some miscommunication, and I don't think this technical team has the film. So that should be perfectly all right.
I will ask our team. Okay, wait.
Acha, she has forwarded to you?
Yes, yes.
Okay.
Just a minute, ma'am. I'll play it.
Yeah, okay. Madam, voice nahi hai त्याला.
World-class amenities, millions of memories. Life is indeed a beautiful journey. And we at Accord Hospital make it a safe and healthy one. World-class amenities, excellent medical facilities, the finest healthcare professionals and seamless procedures symbolize Accord Hospital. Situated in the heart of Pimpri-Chinchwad, Accord Hospital is a renowned and trusted name in the field of healthcare. The hospital is well connected to Moshi, Bhosri, Akurdi, Chakan, Alandi and other cities in close proximity. The tertiary hospital is equipped with 150 operational beds, which includes a 40-bedded state-of-the-art ICU, 5 modular operation theatres, an advanced cath lab, a modern IVF lab, and a 32-slice CT scan machine. Accord Hospital gives its patients top priority and believes that their health and welfare are paramount. We believe that your best days are ahead of you. So we aspire to make your entire experience at Accord Hospital as immaculate and smooth as possible.
We at Accord Hospital strive to give high-quality, patient-centric care that is easily accessible, seamless, and meets the needs of the people we serve. Our institution is built on the culture of transparency, integrity, and compassion.
We aspire to continuously improve clinical procedures and uphold flawless services to ensure medical practices of apex standards. A team of highly skilled doctors, trained nurses, and dedicated staff strive to offer patients a safe, quick, and easy recovery. Intensive and delicate surgeries are effectuated by proficient and seasoned surgeons. We understand the complexity of the procedures and empathize with the patients as well as their acquaintances. Neurosurgery, urology, oncosurgery, interventional radiology, ENT, IVF, and many more are accomplished by our doctors who have unmatched expertise in their respective fields. We also have specialists with mastery in general medicine, general surgery, gynecology, oncology, orthopedics, dermatology, cosmetology, and other segments. Our motto stands firm on promoting a smooth, cost-effective, and fast recovery, and hence a group of committed dietitians, physiotherapists, and mental health counselors assist the patients to attain the same.
USPs of Accord Hospital. We at Accord Hospital offer 24/7 intensive care backup. Our OTs are open 24/7. During emergencies, we deliver the patient right from admission to operation theatre in minimum 25 minutes. We have private as well as public insurance companies tie up with us with 99% of claim sanction. More than 25 corporate companies are tied up with us. We also have full-time retainers in physician, general surgery, gynecology, orthopedician, urology, radiology, ophthalmology, and pathologist. We believe that aforementioned points act as a strength as we strive to continuously provide our patients with the best healthcare and finest services possible.
Accord Hospital acts as a one-stop solution for all medical needs by catering to a variety of specialities and super specialities for the patients. The intra-connectivity of the hospital streamlines the patients with easy access to all the facilities. Accord Hospital has flourished with cutting-edge equipment and advanced methodologies for precise diagnosis and treatment. The X-ray laboratories, CT scan, and pathology sections and pharmacies operate 24/7 to provide top-notch care to the patients. With the aim of making treatment accessible to all, we have incorporated numerous diagnostic tests like color Doppler, mammography, PFT, 2D echo, EEG, EMG, NCV, ultrasonography, stress test, foot scan machine, and all of these are operated by experienced professionals, granting fast and error-free results. We take pride in providing services like a cath lab, laser for urology, neuro microscope, 15 ventilators, an advanced laparoscopic machine, and other state-of-the-art techniques for optimal care. Accord Hospital has been a trusted companion for many. The world saw a wide spread of the COVID-19 pandemic in 2019 and 2020. In order to fight the surge in COVID cases, we at Accord Hospital made various improvisations in a very short span of time, as well as acquired our very own oxygen cryo tank, which helped save numerous lives. Over 30,000 vaccines were administered by us. Your health and well-being is our priority for more than a decade now. Our genuineness has also been recognized by the government. NABH has accredited this multi-speciality hospital, adding value to our word.
We at Accord Hospitals aim to be the largest healthcare platform in the country. We are fully committed to achieving this objective. The team at Accord Hospitals is working tirelessly towards giving back to the society. The company aims to be the largest corporate hospital chain in the state of Maharashtra. Various hospitals are at different stages of completion across the city of Pune, and we believe we can achieve our goal in the coming 5 years with the support from all of you present at this convention.
To speak beyond it, recovery isn't a task for us. It is something we find joy in. Remarkable, reliable, responsible. Accord Hospital.
Thank you, ma'am. Thank you, ma'am, for very
Thank you for
wonderful
this
session.
session. Thank you so much.
Yes. Ma'am, now we'd like to proceed for the question answers.
Yeah.
And many of our
I am seeing lots and lots of them in the chat box.
yes. And the commonly asked question is first, how to diagnose genital tuberculosis? Please elaborate.
So basically for genital tuberculosis, the only test is key on endometrial biopsy. We send the endometrial biopsy for tuberculosis, but many times, or I would say 75% of the times, it is not diagnosed, it goes undiagnosed. And actually, off the record, I do try empirical anti-tubercular treatments and have seen excellent results in these patients. So
Okay.
endometrial biopsy is the only way to see out for the
मैम टीबी गोल्ड टेस्ट का क्या रोल है? टीबी गोल्ड
टीबी गोल्डचं खूप ह्याच्या वाईज अजून नाही हे आहे तर म्हणजे मी तरी
Please use Hindi or English as we have all.
Oh, sorry, extremely sorry.
Yeah,
So TB gold, I'm not quite acquainted with it, and I myself haven't yet used it. I'll be very frank in telling this.
Okay. Ma'am, what is ICD-10 code for infertility?
I think it is 9, and for every type of infertility, it for unexplained it is different, and for female fertility it is different. But mostly it is ICD-9.
Okay. Ma'am, how to do and when to do LH test? Please give the details.
LH basically we do LH test is done for ovulation, and these days we regularly get LH kits. So as we do the pregnancy test, the LH test is done on the kits itself. And what we do is from day 11 or day 12 of the cycle, the patient can do it on a regular basis. And once she at the LH surge, the test will come positive.
Okay. How to increase the endometrial thickness on day 11 or 12 if it is less?
I also don't know. So basically it depends on lots and lots of things. And as I said in my previous lecture also, endometrial thickness or now we call it thickness, but it's basically endometrial receptivity. Endometrial receptivity is a real enigma in our fertility fraternity as well. So there are various factors for endometrial thickness. So basically, if there's no ovulation, there won't be endometrial thickness. But when ovulation is normal and there is the endometrial thickness is less, we definitely have to rule out certain pathologies. As I said in my lecture also, we do the endometrial biopsy, we can do the tubercular test, but these days we do other bacterial tests as well. If we treat this bacteria, many times we find that the endometrium improves is rather because we call it thickness because we can see the thickness on the sonography. So that can be improved with that. There are many other factors like these days we do the PRP installation as well in the endometrium to increase the endometrial thickness. Now PRP installation is done in the prior cycle. We do 3 cycles prior to the IVF cycles.
Do you send endometrium for ERA?
Yes. For in the patients of maybe failure patients, IVF failure patients, we do send it for ERA. But again, scientifically, we do many things. Lots of things are done, but documented. If we have to say that these things are working in some patient that works and in other patient other things work. So it is many times it is patient to patient, and we have to take our practical experience as the gold standard.
Do you use embryoscope?
No. Embryoscope in India, I think it is available in very few centers. We are planning to have it because now we are planning to have a new IVF center chain. So we definitely are planning that to have embryoscope is my vision to have. So
actually,
I think it's fascinating. Yeah.
Actually, that is a very good apparatus. My friend, Dr. Marcos Messeger, has developed that from EV. That's the Valencian Institute of Infertility. I have worked with him. So it will tell you. It will tell you the proper cleavage of the embryo, and then you can select the right embryo depending on the cell division and the fragmentation. So your selection is better for the embryo transfer. So it will be good.
Everything as the patient has to see, the doctor also has to see for the cost.
Sorry, hello? Yeah, can you repeat?
Doctor also has to see for the cost. So we
Yeah,
have
that's the thing. But to select the embryo is really important. I
definitely
think.
it is. Yeah, I said that that is my vision. I am planning to have it. Hopefully, and with best wishes from you all, we will have it soon.
Because
Ma'am, sometimes,
Yeah.
ma'am, sometimes egg not ruptured with 10,000 IU, then what can we do?
So now, see, there are many patients where there is a problem with the rupture of the eggs, rupture of the follicle. These patients, we have to test them for prolactin. Many times I have seen that hyperprolactinemia, it leads to unruptured follicles. So after 10,000, if it is not rupturing, we have to leave them alone. We cannot go on giving them HCGs. This is the most important practical tip which I would like to give you people. And then we have to again see her on day 3 if the follicle is persisting. If the follicle is persisting. So many times it happens that follicle is persisting or it develops into a cyst, and these patients are hyperprolactinemia patients many times.
Okay. No other method.
Here, I would like to comment one thing that temperature of the HCG 10,000 or 5,000 is very important.
Yeah.
If you have maintained the cold chain, then only the effect will be there. Otherwise, it won't get the desired effect. So you have to see the temperature of the injection. So that is very important.
अनम्यूट करावं लागेल मॅम. सेजल मॅम क्वेश्चन्स घ्या. अनम्यूट करा.
हा मॅम. पुढचा क्वेश्चन आहे की
Sharvi ma'am, one question. There are lot of questions in our chat box.
Please.
First, then.
Okay, fine. I'll wait.
Thank you, Sharyu ma'am. पुढचा क्वेश्चन आहे मॅडम. Are asymmetrical follicle like 18 to 13 or 20s to 15 likely elliptical in shape are okay for the treatment? Ma'am, unmute. Please, we cannot hear you.
Sorry. We have to take the average.
Okay.
Yeah.
Next
because
question.
Many times because of the pressure of the follicles, the follicle can go elliptical. So we generally take the average and we say that the average has to be 18 mm.
Okay.
Necessarily, always the follicles won't be circular.
How to do and when to do LH test? Please give the details.
I think it's a repeat question, no, ma'am?
Okay. Sorry. What impact does a woman's age have on her ability to have children?
I think I have explained it now. So as the age increases, you want me to repeat?
Yeah, please.
Yeah. So what happens is with the age, basically a female has got her eggs at the time of birth. So after if the female's age is 30, her eggs are also of age 30. So as we say that there is an aging process in our body, the eggs are also aging. And what happens is at a particular time when we have got a fixed quantity of eggs, we say that there are around 1 million at the time of after the puberty, but only 500 to 600 are available for ovulation. Sorry?
No.
Yeah. So what happens is only 500 to 600 are there for available for ovulation. Once these eggs are exhausted, that female cannot become pregnant with her own eggs because we cannot produce new eggs. So it is said that the 20s are the best age for normal natural conception. Once the female starts entering her 30s, the eggs undergo aging. Now, why this aging happens is the growing follicle, we say that there's one egg which is maturing, but it is not one egg. Along with one egg, there are 3-4 other eggs also which mature along that, but they become atretic. And these atretic follicles, they cause oxidative stress. And this oxidative stress can lead to the destruction of the other eggs. So other eggs become atretic, and that is why the female age is very, very important for fertility. Am I clear?
Yes, ma'am. At what day of period we should do endometrial biopsy?
Endometrial biopsy is generally done at the maximum. We generally do it at around 18 to 19 day of the cycle. But we have to be very, very careful that the patient has to be advised not to have sexual intercourse during this cycle, because we shouldn't take the chance of disturbing a implantation if at all it is happening naturally. So why it is done at 18 to 21 days? We get a maximum endometrium for study at that time.
Okay. How many cycles we can use to treat?
I would like to add one thing here.
Yeah,
These
please.
days, what we do is for endometrial biopsy, we generally don't use a curette, because what we do is it's a small tip from my end. If we are doing the IUI catheter, we can just bevel the catheter, and we can use that along with the syringe for endometrial biopsy. So that will not cause the damage to the endometrium. So we can use the plastic cannula and take the endometrial biopsy rather than using a regular steel curette for that.
But actually, endometrial trauma is itself gives the implantation rate more.
So yeah, but not a rigorous endometrial curette, na?
Maybe not metal curette, but with disposable
So that is what
plastic
we call as
curette,
endometrial
yes.
scratching.
Scratching, yes, because with that also we'll get a more implantation rate.
Yeah.
That's what.
Sharyu ma'am, can I proceed with the other things, please? Role of metformin in treatment of infertility.
Metformin basically we give for the polycystic ovarian patients. Many things I didn't cover because I had already covered those in my previous CA of PCOD. Na? So metformin definitely has a role in polycystic ovarian patients.
Okay.
If the patient has polycystic ovaries and if the patient is infertile, metformin definitely has a role.
Which profession have hazardous effect on female infertility?
I don't see any.
Okay. And
so basically now all professions these days are hazardous because all professions are giving stress, and stress itself is hazardous for fertility.
Okay. And have you any women working in chemical field or chemical factories, or they are exposed to chemicals?
I don't think so. I haven't come across a patient.
Okay. The other question is how much time we should try ovulation induction with tablet, and when to switch over IUI and IVF?
Very difficult question. So I would advise not more than 3 cycles we should stimulate the ovaries, and after 3 cycles definitely there has to be rest period, particularly if you are using clomiphene citrate, because clomiphene citrate has a long half-life. I have seen many times that if we give ovulation induction and if we ask that patient, someone has started the screen sharing. And if we ask the patient to have a break, in that break, patient comes with a pregnancy. So definitely the ovaries need rest and we shouldn't hyperstimulate them more. And we shouldn't go on doing ovulation induction more. We need to understand what exactly is the cause, because if we go ahead and give them continuous hyperstimulation and the patient doesn't become pregnant, it is better we go ahead with the IUI. Definitely IUI can help, but cause needs to be ruled out in a proper manner.
Okay.
I would say not more than 3 cycles. Then 3 cycles we can give a rest. In unexplained infertility, definitely. There are many factors actually. Age of the patient has to be understood. The age of marriage has to be understood. All these things have to be taken into consideration before going ahead with the treatments.
Again, age limit for oocytes to be preserved?
There's no age limit for the oocytes to be preserved, but generally what we do is before the age of 35, it is better we preserve them, because after 35, as it is, there's a severe aging process takes place. But definitely we can do them till 40. Till the eggs are available, we can do the egg preservation. But it is useful, particularly below the age of 35, it will give you a good results because the aging hasn't started that much.
And
I think
How
after Masabite, the boom has come in Pune
Yes. How,
yeah, preserving eggs. So we are running a special program for egg preservation these days.
how is acceptance for oocyte donation or embryo donation in Indian scenario?
Right now, though, we have lots and lots of, as the ART bill has come, we are really facing lots of problems because there are lots and lots of rules and regulations have come up. We have to take the eggs from specific labs. We have to do all sorts of paperwork for embryo donation as well. So I don't think so. The patients are very much ready to, once the patient become pregnant, definitely they will. But for embryo donation and egg donation, there are specific labs and we have to take it from them. We cannot do the egg donation at our own centers these days, unless and until we register for those and then we recruit the patients for that. But most of the IVF centers, they are not doing that. There are special agencies which do this.
And ma'am, can you please explain clomiphene citrate dosage, when to give, how many days maximum we can give, and for how many cycles?
It has to be not more than 100 milligram, I would say. If it is an unexplained infertility or if it's an ovulatory dysfunction, then you can give it to 3 months, then you give a 3 months break, and then you can give it to her again for 3 months. And as I said, age of marriage, the patient's age, other coexisting infertility causes, these are definitely important for ovulation induction.
Actually, here the question was meant like this kind of patients, they go to many doors. So every door has tried this. They start with this. So when
it's very difficult. See, I was finding it very difficult to say that, but many times it happens that the patient has undergone 5 years. The patient has taken continuously. The patient is eating clomiphene citrate and coming. And when actually the patient comes to us, we don't find any eggs. So it would really be my request that we have to use it very, very with a moral consideration. We have to treat these patients because it is very, very important. Pumping her with clomiphene is not going to help her if her tubes are blocked. Pumping her with clomiphene is not going to help her if there is a coexisting sperm factor. I have seen patients getting clomiphene citrate when the sperm count is 5 million. IUIs are being done when the sperm count is 5 million. We have to rationalize it somewhere because finally we have to think for the patient. And when the patient comes down to the IVF centers, many times we have to give them an option of egg donation, which is very, very difficult.
One question is there. Sometimes egg is not ruptured with 10,000 injection, IU injection. What to do?
I think already we have answered that question. I said we shouldn't do anything else, and that madam said we have to check that if the cold storage chain is maintained or not. Yes. But 10,000, after 10,000, we shouldn't do anything. We have to leave her on her own, and we have to do her basal scan in the next cycle that the follicle is not persisting, and then we should see that her prolactin is not high. Hyperprolactinemia many times causes this unruptured follicular. We call it as unruptured follicular syndrome. So these follicles, they don't rupture. We have to see for prolactin. If the prolactin is high, we need to treat for that. And then we should take the patient for induction again.
And we can use the folitropin alpha also. That is arbitrarily, it will give the good result with respect to that.
Ma'am, the question is, can IUI be done as a OPD process directly by using?
You were not audible, I think.
Unmute. Please unmute yourself.
The question is, can IUI be done as OPD process directly by using semen just after ejaculation?
Not at all. The semen sample, it has lots of prostaglandins. Instead of giving you a positive effect, it will give a negative effect. So the semen has to be washed, and the sperm the washing has to be done in the labs, and then only the IUI has to be done. And now again, as per the ART bills, there has to be a special registration for IUI centers as well. In normal, regular clinics, we will not be able to do IUS these days. Because there also we have to keep all the record. For sperm donations also, now we have to tell all the patient details to the lab also for sperm donation as well. And then only we get the sperm samples from the labs. Previously, we used to store at our place. We used to take the samples and we used to store at our place. But these days it is not allowed. We have to send them the patient details and then only we get the sperm samples. So it is very, very important to understand this, because legally it's becoming, with the ART bill now, all these, there will be lots and lots of restrictions on this. And scientifically also, we cannot push the semen without washing inside the uterus.
Best treatment for hemorrhagic cyst?
Cyclical pills is the best treatment for hemorrhagic cyst, but it has to be less than 5 centimeters. The cyst has to be less than 5 centimeters. If it is more than 5 centimeters, then we can watch for 1 cycle. But if it doesn't regress, then maybe we will have to go ahead and do the ovarian cystectomy. But if the cyst is less than 5 centimeters, we can definitely give her a cyclical treatment for 3 months, and there are magic results with this.
Do you think high cortisol due to high stress is causing hypergonedonia?
Ma'am,
and
can
PCOD?
you tell us your success rate of ICSI, please, in your
So success rate in the terms of pregnancy rate or success rate in terms of fertilization?
setup?
Success rate in terms of fertilization or success rate in terms of pregnancy?
She is muted now.
Okay, so
Fine.
we can go ahead with the next
Treatment of
question.
high prolactin levels.
Treatment, huh?
Sorry?
Treatment of high prolactin.
Yeah, so for high prolactin, we give cabergoline, 0.5 milligram weekly for these patients till the prolactin comes down. But definitely we have to rule out the cause for hyperprolactinemia as well. I told you that if there are any tubo-ovarian masses, we have to ask the patient to get a sonography also done, because many times it happens that there are tubo-ovarian masses, and in these patients we have hyperprolactinemia. So we have to treat the infection otherwise also. And cabergoline, previously we used to use bromocriptine, but these days we are using cabergoline on a regular basis.
But do you think high cortisol due to high stress is causing hypergonedonia and PCOD?
In PCOD, no, high stress is basically not causing PCOD. High stress is causing ovarian resistance or premature ovarian failure. Because there is oxidative stress. If there is more stress, is causing premature ovarian failure.
Someone asked treatment of torch.
Torch.
Treatment of torch, yes. Torch test. If torch test positive.
But torch मध्ये काय positive आला तर?
No, only question is torch. Treatment of
because for toxoplasmosis, we give spiramycin, and if it is cytomegalo, most of the times the cytomegalovirus comes positive. Again, IgG, IgM, that is also very, very important. Ki IgG antibodies आलेले आहे, IgM antibodies आलेले आहे. हे पण important आहे. So त्याच्याप्रमाणे we have to give them the antiviral. But for toxoplasmosis, we give spiramycin, and for 21 days for 3 months.
Ma'am, how to manage the stress of a couple when everything is fine, but they don't achieve pregnancy?
These days, we have a counselor for that.
Okay.
And see, holistic approach is very, very important. Jokes apart, holistic approach is very, very important. So during IVF cycles, we definitely advocate yoga. We advocate them specific meditation cycles also for this patient. And these days, we have a professional psychologist who counsels this patient, because to keep the psychology up is very, very important for these patients. So we have to hope for the best and be prepared for the worst.
Treatment for high prolactinemia levels?
I think I have already covered that. It's becoming a repeated question.
That has covered already.
Thank you, ma'am. I think we have covered almost all questions, and people, I mean, many of them want to know how equipped is your IVF center and
Hello,
what is
ma'am.
the success rate and all that,
Yes,
ma'am.
yes, ask ma'am, ask your question, please.
Okay.
Ganguly
Thank you,
ma'am.
ma'am. Thank you. Ma'am, nowadays young patients have low MH value. And what are the reasons and how to cure?
So see, low AMH, we don't have to treat low AMH. Now we have to treat the ovarian part of it. Now, low AMH itself denotes that she is having premature ovarian failure. So if she is having premature ovarian failure, we cannot do anything to get new eggs. If the eggs are less, if she still has eggs, we need to advocate that she has to undergo the treatment at a rapid pace. Because in these patients, we have to advise them IVF as soon as possible, because if we wait for these patients, she may end up in complete ovarian failure and we may not get eggs for her further treatments. So basically, it is very, very important to understand this. Ki we cannot treat low AMH, we cannot treat premature ovarian failure. And if it's a complete ovarian failure, these patients have to be advised with egg donation.
Okay.
Hello.
Okay.
Ma'am, thank you so
1
much. I
second.
have one question, ma'am. Dr. Sushma here. Ma'am,
Yeah.
I want to know the prognosis. Actually, my own sister, ma'am, she had 2 IVF failure cycle. Then it was unexplained infertility. Again, they went for the IVF cycle. She conceived with ectopic pregnancy. Then that was means as usual laparoscopic right self-injectomy done. After that, again she had developed cyst of 7 centimeter. Then they laparoscopic, then operated. Now the when that cyst was means osteoblastoma, they were thinking like cancer or something. So they sent for the biopsy. Now the thing is she has endometriosis, ma'am. The thing is it was unexplained.
Endometriosis was not diagnosed previously?
No, it was unexplained infertility. Age is increasing, 35 age. She started now is 37 age. She means underwent 3 cycles of IVF. First failure, second ectopic, third embryo transfer failed. Now she is suffering with endometriosis and she is having cyst. Now she took OC pills. These are the queries. I want to know the prognosis.
What can we do is, can I just put my number in the chat box and you can just send the reports, because I think I will require a detailed reports also, ki why the IVFs failed and all those things. So I can, or Dr. Pradnya can forward my phone number.
I will forward the number of
you can forward the number and you can definitely get in touch with me on WhatsApp. Shouldn't be a problem.
Thank you so much, ma'am. Just wanted to know prognosis.
Definitely, I will help you out. Shouldn't be a problem.
Yeah, ma'am. We are grateful. We are listening. You explained in detail. Actually, everyone is understanding.
Thank you so much.
Thank you so much, ma'am.
Ma'am, we have second last question. That is, what is your view about HPV vaccination?
Acha, it's out of my topic actually. But
out of syllabus question.
It's out of syllabus.
HPV vaccination.
Yeah, definitely. No, I would definitely advise vaccination, because all my niece and who are my daughters, I have definitely given them the vaccination. So yes, definitely I do advise HPV vaccinations.
One question is there in secondary infertility. What are the tests should be done, and what is the main cause for
secondary infertility? If it's an infertility, it's an infertility. It has the causes and the investigations and the treatments have to be the same. We have to rule out all the factors, because many of these factors are acquired factors. So there can be new thing coming up, because it's a body. So maybe in the previous pregnancy, there was no tubal block. She can have a tubal block now. There may be a polyp, there may be a fibroid in the uterus, there may be certain, she may have PIDs. So it's same. The course remains the same. I don't think so the course differs in secondary infertility. That is why I didn't define primary and secondary infertility as different.
Okay.
But yeah, history changes, because maybe she has undergone MTPs or something like that. So according to that, maybe the investigations will change, but the basic course remains the same in primary as well as secondary infertility.
Thank you, ma'am. Now, I would like to call Chairperson, Dr. Baljot Kaur ma'am, for her views and opinion. We should give time to breathe and drink water. Ma'am has been exhausted and we have short lot of questions.
Sorry.
So Baljot Kaur ma'am, please.
Otherwise also I regularly drink water regularly. So I need water.
Yeah, Baljot Kaur ma'am.
Yeah, good evening, everyone. I just first congratulate NIMA Women's Forum Maharashtra for coming up with this lecture series on infertility, and they are very informative. And I thank Dr. Anushri Mundewadi Madam, Dr. Pragna Khose Ma'am, Dr. Meenakshi Gawi Ma'am, Dr. Pallavi Mane Ma'am, Dr. Shilpa Korane Ma'am, and Dr. Sheetal Asutkar Madam also. So, and I'm really congratulate you for these lecture series. And I really thank and congratulate Dr. Deepali Chinchole Madam for your very informative, extensive and in-depth knowledge you have shared with all of us. And there, I'll say you have given each and every detail and in the practical aspects also. So this is more relevant, and we can connect to what you have said, that it will help in the treatment of the patients. And like, since you covered all the main topics, like when the patient comes, so how we should proceed, you have made it very easy, and you have taken all the points in a very detailed aspect. And regarding the question answer session, you have cleared all the doubts, and with your inputs and with your experience, I think all the participants, they have got the feast of knowledge, and they have really gained from your experience and your knowledge. So coming to, I would like to share a bit of the Ayurvedic aspect, since you have given the definition of infertility with the emotional and spiritual aspect. Maybe Ayurveda has also considered the emotional and mental aspect, like from your menstrual cycle, from the sperm morphology, and this diet and the lifestyle of the patient. This is very important, and her emotional and mental status. All these factors, they do affect the outcome in the infertility. And regarding all the aspects of infertility, rather it's like vaginal, cervical, uterine, fallopian tube, ovarian, Ayurvedic treatment, basically Panchkarma and medicines, they really help to getting treated all these conditions. So in my experience, Uttarvasti gives very wonderful results in the endometrial thickness, and the response is also good. And when a patient is going for IVF, before that, if the patient goes for Panchkarma or the Ayurvedic treatment and the Uttarvasti aspect, then we get better results in IVF. So I suggest usually for my patients also that you first go for the Ayurvedic treatment and then go for IVF, and we get better results. And in all these conditions, Ayurveda also gives better results. So I congratulate and thanks NIMA Women's Forum and Dr. Deepali for a wonderful presentation and wonderful webinar series. Thank you so much.
Thank you, Baljot ma'am. It was very nice of you to share the knowledge about Ayurveda also on this. Now I would like to come to the final session, that is Thanksgiving. And I would say appreciation is a wonderful thing. It makes what is excellent in others belongs to us as well. Personally, I would like to thank my President, NIMA Nashik President, Dr. Deepali Bade ma'am, for granting me this opportunity to be on this vast desk and forum. On behalf of NIMA Women's Forum Maharashtra State Branch, I, Dr. Shejal Sanghvi from Nashik, would extend my warmest thanks to today's delightful and wanted speaker, Dr. Deepali Chinchole ma'am, for her detailed audio, video presentation and justifying today's expansive topic with extensive question answer sessions satisfyingly. It was a very enjoyable session, ma'am. I appreciate all the national PST members and IPP ma'am for their presence and wishes. I'm grateful to all the Maharashtra State State PST members and IPP ma'am for their hard teamwork and organizing this online webinar series. I want to acknowledge their dedication and efforts on this platform. Thank you so much, ma'am. I would like to also give credit to National Technical Team, Dr. Girish Daga sir and Dr. Manish Joshi sir, without whom we couldn't have done this session successfully. Lastly, I would like to express my sincere words of gratitude to all the delegates who and everyone, I mean, if I'm missing anyone, who is present today and making this event successful. For this webinar, a very, very successful. I mean, we had the maximum attendance today. It was around, we crossed on Zoom more than 200. And due to some technical problems, others all shifted on the YouTube session. So it was a really vastly appreciated session by all. So thank you so much. Thanks a bunch to all the IE organizing members, Deepali Chinchole ma'am, and everyone. Thank you.
Thank you. Thank you so
Technical
much.
team, so for Silpa Koranne and team. Thank you.
Yeah, thank you.
Thank you, everyone.
Thank you.
Thank
Yeah.
you.
Thank you, everyone.
Thank you.
Yeah.
Thank you, Valpur ma'am.
Yeah, thank you so much for giving me this honor and opportunity. और बहुत अच्छा लगा.
नहीं,
And
हमें भी
all the
बहुत अच्छा
best
लगा.
for your future.
बहुत अच्छा लगा आपसे मिल. Thank
जी,
you.
ma'am.
Thanks on behalf of all NIMA family, ma'am.
Thank
Yes,
you,
ma'am.
thank you. Thank you.
We could finish our session before time.
Yes.
Yes.
That's 4:50
10
and
minutes before.
And very good
All
anchoring.
are
that's better.
sincere
Anchoring is
students.
also very good.
Sincere students. We all before time exam khatam kar liye.
Yeah.
Yes.
Yeah, there
Thank
were
you, Meenakshi
काफी
ma'am.
question answers थे and patients के साथ में और बहुत
patients
detail में
का
अच्छे
कमाल
से
है।
किया हमने.
हाँ.
Yeah.
That was
That's
really
good.
Very अच्छा explanation. Both her lectures were
Really nice explanation.
splendid.
Really good, especially उनका जो practical और experience जो
Practical
उन्होंने
approach.
share किया है ना. And last
Yes.
lecture भी मैंने सुना था, so वो भी anatomical aspect with like practical aspect, that was really good.
Yes. Yes.
Usually ऐसा होता है कि सब ऐसे सब बता देते हैं कि ये चीज है, but उन्होंने practical aspect अच्छे से लिया उसको. It was good.
Yes.
Videos were super.
Yeah.
Okay.
yes. Shall I take your leave then, ma'am?
Yes.
Yes, yes, sure, ma'am.
Yes. Thank you.
Okay,
Bye-bye.
thank you. Thank you.
Thank
Thank you.
Bye-bye. चलो.